we're doing very well at staying on time, which is great. Our next talk, Managing Stroke and Bleeding Risk in Patients with AF. Where do drugs and devices fit in the spectrum? Dr. Valderrabano, Chief of EP from Methodist DeBakey in Houston.
Thank you. I sure do have the longest title. We'll try to make it not the longest talk. But this will set the stage for the rest of the symposium, because we will go over the clinical dilemmas that justify appendage exclusion. So we know that when you have atrial fibrillation and you have stroke, this is because of stasis in the left atrial appendage. That's basically what AFib does to your left atrial function. We also know that up to 25% of the strokes that occur in patients with atrial fibrillation could be related to other coexisting risk factors. So when we look at risk factors for stroke in AFib, it turns out that the most effective ones in the clinic have been those that are epidemiologically based, such as the CHATS-2 score and the CHATS-VASc, as I will go into more detail. And the mechanistic risk factors for stroke in AFib have yet to be validated. I'll go over some of those because I think the future is here. Relating left atrial appendage inflow velocities as a surrogate for a precursor for stasis and clot formation in the left atrial appendage, spontaneous contrast, new data from Utah about the role of left atrial fibrosis, the left atrial anatomy, which will be discussed in detail by Dr. DiBiase tomorrow, whether AFib is paroxysmal or persistent, the burden of AFib, left atrial appendage morphology, and also some hemostatic factors may play a role. And in the future, I'm sure we're going to get more refined as to our ability to estimate the risk of stroke in AFib. But going to what we have in the present, the CHATS-2 score has been very useful for the past decade. And just briefly remind you, congestive heart failure is the C, H is hypertension, A is age more than 75, D diabetes, and you get 2 points for a TIA or stroke. And you can see how there's almost a linear relationship between the score and the increased risk. However, the CHATS-2 score has a lot of problems. We know that the risk of stroke in atrial fibrillation increases from the age of 65, and that's not captured in the CHATS-2 score. And it goes up by 1.5-fold per decade. So ideally, we need to account for earlier ages and increase the weight of older ages in estimating the risk. The CHATS-2 score fails to predict low score rates. So it is critical to decide whether the risk is enough to justify anticoagulation, and the CHATS-2 score does not do a good job in that regard. It fails to account the increased risk of stroke in females, and in a prospective evaluation of its validity in a patient population of lone AFib, de novo diagnosed patient population of lone AFib, followed for 10 years, it turns out that the CHATS score the CHATS-2 score did not predict the risk of stroke. The C statistic was 0.5, which, to put it simply, is equivalent to chance. So basically, you could pick randomly which patient will have a score, and it would do as well as the CHATS-2 score. So it is really imperfect. To solve these weaknesses, we have the CHATS-VASc score, which addresses the increased risk of stroke at age 65 or older, and it addresses the increased risk of stroke in females. And it does have also some linear correlation between the risk of stroke and the score. Perhaps more importantly, it does very well at discriminating those patients that have very low risk of stroke, in whom you can safely not give anticoagulation. How about mechanistic risk factors for stroke? Well, again, the inflow velocity is basically the core of the matter. This is where, this is how you measure how much stasis you have in the appendage. And you can have very brisk contractions, like you can see here, or less brisk or no contractions at all. And it's very hard to predict based on clinical factors whether a patient will have meaningful contractions of the appendage or not. It is always a surprise or a kind of a gamble when you do a TE and you don't know what you're going to find. The TE findings, as far as inflow velocity, spontaneous contrast, and presence of thrombus, have been correlated with the CHATS-2 score as far as low risk, moderate risk, of high risk. But we do not have a prospective validation of TE findings, inflow velocity, and spontaneous contrast, and the subsequent risk of stroke. These are just correlation between risk factors and TE findings. So we don't have that. Is paroxysmal different to persistent or permanent AFib when it comes to the risk of stroke? It's not. When you look at the more recent data from the RELY trial, which was 18,000 patients randomized to dabigatran and warfarin, as I will discuss in a few minutes, and you look at the incidence of stroke in patients with paroxysmal AFib, persistent and permanent, compared to in warfarin, warfarin here, compared to dabigatran here, it turns out that the risks are very similar in all three AFib types. So in this large population, it didn't seem to make a difference whether your AFib is paroxysmal, persistent, or permanent when it comes to the risk of stroke. However, if you look at, again, a large population with a de novo diagnosis of AFib, in which you follow these patients for 10 years, it turns out that in this population that have very low risk of stroke to start with, the progression from paroxysmal to permanent, or for persistent to permanent, did have an increased risk of hazard ratio of up to 15 times when it comes to the risk of stroke. So the data is still yet to be clarified, but it may play a role. A few words about atrial fibrosis. The EP part of this audience will be familiar with the work by Nasir Marouche correlating late enhancement on the MRI with atrial fibrosis. It turns out that the more fibrosis you have, if you delineate different degrees of fibrosis, the so-called UTAS scores, it turns out that the more fibrosis you have, the higher the prevalence of a history of stroke. This is, again, a retrospective validation. We don't have prospective data. But basically, stage 4 fibrosis, which is more than 21% of the left atrial surface, correlated with a much higher rate of prevalence of previous stroke. And I also did with the CHAT score. We do not have prospective validation as to whether this index of fibrosis correlates with future risk of stroke. How about AFib burden? Do we know whether more AFib correlates with more stroke in patients with paroxysmal AFib? We don't. We don't have the data, but we know how little AFib is required to increase the risk of stroke. And it is very little. This is data from the ASSERT study, where they looked at patients with pacemakers, and they followed those for subsequent risk of stroke. And as little as 6-minute episodes of atrial height rates of more than 190 beats per minute, this is not really clinical AFib, led to a hazard ratio of stroke of 5.6. So we don't know that one episode of AFib every other week versus every other month do have differences in AFib stroke, AFib-related stroke, but we know that very little AFib, in fact, just atrial height rate episodes do correlate with increased risk of stroke. What do we do to prevent strokes? Well, we know warfarin has been there for decades, and this is the data that supports the use of warfarin. Studies, multiple studies, about 400 patients in each of them, validating that warfarin does decrease the risk of stroke. Newer anticoagulants, dabigatran, we know that it's not inferior to warfarin, and in the case of dabigatran, 150 milligrams twice a day is superior to warfarin. But it's interesting when you look into the details as to what kind of strokes dabigatran prevents. It turns out it does a great job, a phenomenal job at preventing hemorrhagic strokes. These are strokes that you could consider iatrogenic strokes. These are the strokes that we cause by giving blood thinners to patients, right? Dabigatran decreased the risk of hemorrhagic stroke dramatically from 0.38% per year in the warfarin group to 0.1 in the dabigatran 150. As far as the ischemic risk of stroke, it is decreased from 1.2 in the warfarin group to 0.9, but the difference is less dramatic. About preventing hemorrhagic, i.e. iatrogenic strokes. But when it comes to ischemic strokes, these are the strokes that are created by AFib. It's really not significantly better than warfarin. And the same thing happens with apixaban. Overall better than warfarin at stroke or embolism, and less bleeding for sure. And then when you look at hemorrhagic, ischemic or uncertain type of stroke, the differences are not significant. 1% per year in the warfarin group, or 0.97 in the apixaban group, whereas the hemorrhagic stroke did decrease significantly. So you figure that if you had a therapy that took care of the AFib-related strokes, those are the ischemic strokes, without causing any hemorrhagic stroke, it could be even better than warfarin, and for sure than the new anticoagulants. How about the risk of bleeding? The risk of bleeding with warfarin in the RELY trial and apixaban and the rivaroxaban trial was about 3% per year. It turns out when you look at real life outside clinical trials, the risk of bleeding on warfarin is up to 6 to 8% per year, much greater than in clinical trials, and particularly much greater in patients that are older than 80 years of age, 13% per year in those patients. So it's quite a significant problem. Do we have any real-life data on the bigatran? There's an observational study from UAB when they looked at the actual risk of bleeding in an observational cohort of theirs, and they showed that on warfarin they had a risk of bleeding of 7.6% per year, and in the dabigatran group to almost 9% per year. So life is different outside clinical trials, and the risk of bleeding is much more important. We do not have such data for apixaban or rivaroxaban. So how do we estimate the risk of bleeding? We have risk factors. The most commonly used, the best validated risk factor scheme is the HAS-BLED that has hypertension, abnormal renal or liver function, history of stroke, bleeding tendency, labeled INR if on warfarin, age more than 65, drugs or alcohol. You can see how of these risk factors, all but 2 are identical to the risks of stroke. So the more risk of stroke, the more risk of bleeding. And again, there are other risk factor schemes to predict the risk of bleeding. I won't get into details, but the HAS-BLED is the most useful in clinical practice. So you figure that if you had a way to prevent ischemic strokes at their origin, which is the appendage in most cases, without causing hemorrhagic risk, you would be golden. And that's where left atrial exclusion devices come into play. I'll discuss briefly the Watchman device, which is the one we have the most data for. The PROTECT-AF study was a non-inferiority designed study looking at patients with a CHAT score of 2 or more, and they looked at a composite efficacy endpoint of ischemic stroke, cardiovascular unexplained death of systemic embolism, and a safety endpoint, which was bleeding for warfarin or procedural complications. The trial had to pay the price of operator inexperience, and there were procedural complications, there were less than optimal success rates at delivering the gadget into its place. When you look at the on-treatment result, the hazard ratio is 0.4. I'll show it here. So when you look at the primary efficacy, it's 0.4. It's a 60% reduction in the primary efficacy in the patients that had the Watchman successfully delivered. It's unfair. This is not intention to treat. This is as optimally you would want everything to be, but it does show that it works. And if you look at the complications, the reasons why this did not really have a stellar performance, well, there were 6 peri-procedural strokes. 1 occurred prior to the procedure, but because of the intention to treat analysis, it has to be counted. 5 due to intraprocedural air embolism, which really you could take care of with more experience. This requires a complex sheath, and you have to go back and forth, and it's relatively easy if you don't have experience to get air into it. When you look at the post-procedure risk of stroke, it was 1.3 per 100 patient years in the Watchman group compared to 1.6 in the warfarin group. Effusions 5%, and three device embolizations. When you look at subsequent data, the CAP registry data showed that the total risk of stroke of the procedure could be reduced to 0 procedure-related strokes. So there is room for improvement. And just last week, we had the long-term follow-up data presented showing that long-term, the data still holds true that this device works. So decisions. How do we balance the risks here? Well, currently, we recommend anticoagulation for any CHA2DS2-VASc score greater than 0. Okay? So that's equivalent to having more than 1.5% risk of stroke per year. When you do anticoagulation, you're going to buy a risk of bleeding, and which with warfarin, depending on which numbers you believe, could be 3.5 to 13%. The bigatran, we know it's 3.1 versus 8.9 in real life. We don't have real life data for rivaroxaban or apixaban, but the risk of stroke does get decreased. I'll be finishing soon. This is blinking. The risk of ischemic stroke does get decreased significantly with the bigatran, but not with the others. The risk of stroke with Watchman does get decreased overall, but Watchman's best data is a decrease in cardiovascular unexplained death. I don't have an explanation for this. The risk of stroke is actually quite similar in warfarin versus Watchman. So we'll still have to figure out how to best manage this. So some clear cases as to how do you put together the options, or anticoagulation or appendix exclusion treatments. There are some clear cases. So if you've had a prior life-threatening bleeding from an uncorrectable source, it's obvious you need to look for strategies for LA appendix closure. If you've had a prior stroke, the data presented last week by Vivek in the long-term follow-up of the Watchman study shows the risk of recurrent stroke in AFib patients with Watchman is 5.3, which appears high, but in warfarin is 8.2. We know that AFib is a pervasive risk of a cause of stroke because it tends to recur more than other causes of stroke. If you've had a prior hemorrhagic stroke, you really cannot give anticoagulation. Or failed anticoagulation. If you had a stroke or systemic embolism on oral anticoagulants, you got to look at other strategies. Dialysis population, I don't have time to get into it, but it's very interesting that warfarin in this population increases mortality. So it's something that you want to avoid risk of bleeding. Of the available strategies for LAA closures, in the US, we have Watchman under the CAP2 registry, Lariat, and surgical strategies. I list here the individual characteristics of each. Basically, the Watchman is non-invasive, is procedurally suitable for most patients. We have solid outcomes data, requires transient anticoagulation, but you implant a foreign body in the circulation, and you cannot use it with the presence of LA thrombus. The Lariat is more invasive. It has limited patient suitability. You cannot do it in patients with pericardial anatomy and in certain LA anatomies. We have no outcomes data. It's unclear whether it requires anticoagulation. Most of us prefer to give it because there's some reports of stump thrombi. You don't have a foreign body implanted in the circulation, which is attractive, and you can't use it with the presence of LA thrombus. Surgical treatments are invasive, obviously. There's a reduced patient suitability. Not everybody is a candidate. You have no outcomes data. In fact, the outcomes published are not encouraging. And clear whether you need to anticoagulate. You do have an external foreign body implanted, and it may be okay with the proper surgical experience if you have a thrombus in there. So just to conclude, the risk of stroke is broad in the patient population with atrial fibrillation, which basically shows that AFib is more than one disease. Individual risks derive from indirect estimates of conditions leading to LAA stasis, coagulability, or endothelial cardiac dysfunction. The CHA2DS2-VASc score is the best we have, particularly low-risk individuals. And the future is to come up with mechanism-driven risk factor assessment for stroke in AFib. As far as the bleeding risk is an unavoidable effect of anticoagulants. The incidence is much greater in real life compared to clinical trials. Risk factors of bleeding overlap with those of stroke. And newer anticoagulants have less hemorrhagic stroke but similar bleeding overall. When to close the left atrial appendage? Clearly, when we've had failed anticoagulation, recurrent stroke, prior bleeding, or hemorrhagic strokes. And we need to individualize stroke risk, bleeding risk, technical feasibility, and procedural risks. And I'll stop here. Thank you. Super.